question about the Radiprodiel trial. Here. So did you measure also cognitive improvements, or it was not part of the trial? And if you have some observations about it, or it's still an issue?
Yeah, that's a good question. We some of the non-seizure endpoints were like the ABC 2C, as well as we're measuring motor. We in this 1B we did measure some motor function. So to your question, nothing in depth for this as far as cognitive function, but we did as we think about the pivotal phase, we're also thinking about how to assess these non-seizure endpoints a little bit more in depth.
I think it's helpful to understand that assessing non-seizure endpoints can take some time. And, certainly conversations with regulators include conversations around how much time you need to assess something like a change in cognition, and be able to look at the difference. And this is just for educational purposes, but to look at the difference between what would be normal development in that time course and what would be a change in development. And so it is quite complicated to measure in a trial, of course, but certainly part of what we're discussing.
No? Okay. So this is a question for Leipzig team. The first is a very naive regarding the genes to face recognition or face to gene software. So are you including also the siblings or sisters, brothers? Because I don't know if there is like a family difference, facial difference. And the second question is regarding the memantine studies. So I was a bit surprised about the ratio of gain of function variance in GRIN1. It's like half of, almost 50% of the annotations are corresponding to gain of function, which it was a bit surprising. And I was not completely understanding the rationale of administering memantine to loss of function individuals. So if you can just clarify, thank you.
Yeah. So first, no, we don't include siblings. Of course, there may be some similarities. I think we have one pair of monozygous twins that both are affected, but no, we don't compare it familial similarities. We just take the isolated index cases. And for memantine, we don't understand the rationale either, giving memantine to loss of function cases that were published in the literature or that were contributed to us by anyone else that had said, I have a GRIN case that was treated with memantine and it helped or it didn't help. And we collected the data and then found out, well, it's a loss of function.
We found out retrospectively that it's a loss of function. We
didn't suggest to do that.
And the proportion of the GRIN1, I don't know, maybe because we had a main focus on the GRIN1 project, or I had the focus on the GRIN1. So we asked especially for memantine treatment in this cohort. So maybe this is why we have more GRIN1s, but I don't know.
Hi. I have a question about the GRIN1. So that's you, Luna?
Yes.
So based on my talk, like for the loss of function, we rarely see cerebral palsy in the GRIAs. And maybe that's the way where GRIN and GRIA differ. Yeah. Or maybe not. I was just surprised to see that a lot of your, like both your gain and your loss had a significant proportion of cerebral palsy diagnosis. So I was just wondering, do you quality control somehow in your database whether that cerebral palsy is really a cerebral palsy? Because or is it just the families? Of course, it's families reporting, but like I was just surprised. And one way of going about this is to sort of quality control whether it's really cerebral palsy. Do they really have Babinski and hyperreflexia and so on, or is it like you get what I said? So I'm trying to
Yeah.
understand the GRIN disorders. I'm just surprised that you see so many with cerebral palsy in the loss of function, where we see hardly none in the GRIAS. I'm just trying to understand.
Yeah, I think it's a good question, and I'm afraid that I can't answer it completely. But for some cases, we have very good data, and we have medical reports, and we have the data from the parents and from the clinicians, and we can combine it, and we medically evaluate every entry in the registry. But sometimes we only have the data from the patients or from the clinicians, and from our point of view, it's better to have this than to have nothing. But this sometimes make it hard to assess if it's really cerebral palsy or not. So in the end, I can't answer your question completely, but we can have a deeper look into the data afterwards if you have a special interest in. So it's not yet published, but we can set a focus on this and look at it again.
Sorry. Alain, you know that cerebral palsy is a bit more precise than headache, but not more than that. I mean, unfortunately, at least for my generation, this was a diagnosis that we were putting everybody walking on tiptoeing, and the other way is cerebral palsy, and so on. How you differentiate that really? I mean, you are asking for a control. What should they use? Do you have one? Because the Babinski are okay, but
I don't have all the answers. Ideally, we would have a referral center, and this requires money, but it could be like an opportunity to have a referral.
Oh, you mean
but like,
selecting the patients with the same diagnostic error? That I agree. This is
having
probably the best way
of doctors seeing these with the knowledge of cerebral palsy to say, okay, you don't have cerebral palsy, you have cerebral palsy. But in our database, because I encountered this problem, because I initially I initially thought this was a good question. So what we did was we sort of said, okay, if you have cerebral palsy, do you have one tick off hyperreflexia, clonos, Babinski, muscle stiffness? So we sort of asked further questions about this, if in case they had cerebral palsy. Yeah.
A lot of children at a young age get a diagnosis of cerebral palsy,
And they don't have it.
Later it turns out to be GRIN disorder, and then not always that diagnosis.
It's also something that even in the US we use, or often in the US we use to get access to services. So you might get given a CP diagnosis so that you have early intervention services and things like that. Same with autism diagnosis if you have an unspecified neurodevelopmental disorder. So that, at least in the US, I don't know if it happens in Europe as much.
Yeah, just a really quick naive question about the mosaicism. You kind of talked about all the tests you can do. In theory, you could test the ovaries. I mean, you know, with IVF, you do harvest eggs for that. I mean, if it was important enough, I guess in theory you could see if the mother was mosaic and potentially the source of the genetic abnormality.
Yes, in theory we can, but in practice not.
Yeah, well, I guess.
So we face the problem, or we plan to face the problem with mice. So where we can get the oocytes or the ovaries. Yes.
Can you do it by a process of elimination once you've done all of the other things? Is that the most likely thing that's left, or in terms of like the source of the genetic change, whether it's something that could recur in future children for the mother? I just mean if you've taken the eyebrow and you've taken the sperm and you've taken the cheek swab and nothing is the only thing left that it could.
Yes,
it
it
could
is
be
the only thing.
okay.
Yeah.
Oh, okay, in that case, yeah, don't do it.
Yeah, so it's the only thing left, and we have found the 2 mothers only with the mixed mosaicism because we cannot find the gonadal mosaicism in the mothers. Probably they're the most least case because the gonadal mosaicism are more likely to occur in the fathers. But yeah, the data is very few on this.
Hilary, one for you. But it is more on patient issues. I have the impression for years now that the patient referral to centers that perform a trial, even if they live far away or they are followed from other teams, is much easier in the US than in Europe. Is it true? Is it fake news? or do you have an explanation?
I think in some ways it is easier in the US. I think that there, as Americans, we tend to consume healthcare differently. And so the idea of going somewhere specific to receive expert care, I think is a little bit more comfortable for us, and it's allowable, right? So, you know, I travel 4 hours away to get all of my daughter's care because it's the best, you know, that I can get. And that's part of my process. And if there was a clinical trial somewhere, I might travel for that and I wouldn't think much about it. So yes, I think there's comfort with the traveling, comfort with the seeking of care somewhere that isn't your sort of home base. And
probably the reimbursement issues are also easier, no?
I imagine
At least from the trial, not from
Well,
the
for-
public system.
Y-
Well,
Yeah, I'm not sure I could speak to that, but I do think also because we're a big country, there's a lot of comfort with sharing patients too. So I think that the clinicians all kind of work together to make it as easy as possible for families.
Hillary, in the US, isn't it generally the case that the patients don't pay for the trial?
Yeah, the patients do not pay for anything
Yeah.
in the trial.
In the United States, that kind of healthcare would cost a family 50 grand, 100 grand. So getting it free in a trial, most parents are like, let's do it.
Yeah, there is a benefit, of course, to seeing someone who's an expert in the condition, right? And I think that's true anywhere, but certainly in the US, yeah.
I have a question for Chris and Russell. I picked up as Chris did on the dosing or the application of the drug was through tube or orally. Whilst I think the original dose, I may be wrong, was actually a pill. Is that correct? It goes in a 10 mg.
That's correct.
Yeah, so you changed really formulation of this, and then you measure plasma levels in your PK. Did you see a difference, or is the N too small to see a difference depending on the route? And what regulatory, you mentioned that, Chris. How did you get around that regulatory-wise? I understand, of course, the medical necessity of giving feeding tube versus oral. I mean, just is what it is. But how did you get around the regulatory?
So that had to be established, the equivalence and between the different formulations before we initiated with the 1B. So that process, and Chris is an expert on that we needed to demonstrate the equivalence.
Non-inferiority of
the adult studies in neuropathic pain were pills and versus the suspensions that we have for the kids. Yeah.
But the suspensions actually predated this study because in the infantile spasm study which was also pediatric. We began with the formulation that was already in use in children in that study.
Yeah, if I can just add as well, I've worked on a study for repurposing, which was a rare disease as well, and they had a similar issue where they had a product that was on the market but wrong strength and this and that, and they were asked by the EMA to adapt it for feeding tubes and do comparabilities and this and that, and then there was this big discussion for a long period of time because the PDCO, the pediatric committee, always asks for too much. But basically they came back and said, well, we've talked to our KOLs. There's only 2 patients they've ever seen in 8 years in this range. Why should we make a special formulation to put in a tube for the 1 patient who's going to come in 4 years' time? And so in the end, they actually got removed the obligation to make the formulation, but they had to do a registry evaluation of how the patients are using the product off-label when there's no dosing recommendations and so on, and some of them can't swallow and stuff. So it's a complicated area for sure of pediatric formulations.
Can we expect that the great flexibility that you pointed out that may be coming would help overcome such kind of necessity or non-necessities? You know, testing different formulation. Well, we just know it's fine, it's going to work, whether it's going to go to the same point, last 10 centimeters below. Do you see that, for instance, and what are other eases that may come with a little bit more flexibility?
Yeah, I mean, it depends on the product as well, because maybe you can do other routes of administration or other formulations, and maybe for repurposing especially, you need to have incentives, and one of them is patenting formulations and different routes and trying to change something to make it novel, if you know what I mean. So maybe there's interest in doing that as well, but unfortunately it's a case by case. The EMA or FDA would just tell you what they want to see. But PDCO and EMA tends to be very demanding, and people complain a lot about that, but maybe that's a good thing because they ask for quality studies, you know, so yeah.
Okay, Sonia, all our genetic reports say that germ cell mosaicism has not been excluded. And I was wondering if you have, of course, a wish for a second child, if it's possible to exclude it, if they do that in a genetic evaluation, because obviously when you start investigating, an egg cell or a sperm cell will be destroyed in the investigation. And if you would find it in one egg cell, is that a guarantee that the others would have it as well, or how does that work?
Yeah, that's really the end point of our study. So even if you do a very deep sequencing of all the materials I have shown, there may be still a second egg cell or a second sperm cell that has the variant in it. Yes. But the chance is very, very low compared to the standard diagnostics we do at the moment. So we do only the most times the Sanger sequencing for segregation analysis in the parents, and that is blind at a below allele fraction under 20 or 15%. And we have found in our study most cases are below. So it's not detectable with our routine diagnostics. But yes, there will be never a 100% result if you don't do the prenatal diagnostics on the second child. Yes. But there's some kind of, yeah, you can do an individualized genetic counseling, and that may relieve most of the parents, most of the families of the higher recurrence probability. But we still don't know which families they are.
Hi, so question for Chris. I've said before, we're from the UK. Does our system in the UK, does it mirror more the EU in terms of regulation? Is it the same? I'm not very
Yeah,
with it, but
it's pretty much the same because obviously it was the same before Brexit, and since Brexit, there's what's called the Windsor Agreement. So they've changed a few things, especially about Northern Ireland, and now added a few things. But otherwise, it's exactly the same. They just have different names and numbers instead of the numbers I presented before. So yeah, but otherwise the same.
great, thanks.
Hi, my question is related to visual recognition. So what was the algorithm behind that model? And what was the reasoning to choose that particular algorithm? Because there are multiple algorithms available for the facial recognition.
I didn't really understand the question. Could you repeat it?
So, as you were mentioning that by taking the photo, you were classifying the.
Yeah.
So, what was the algorithm? You mentioned about the algorithm, that algorithm is predicting or classifying. So, what was the algorithm? And secondly, what was the reasoning to choose that specific algorithm you were using?
Okay, the algorithm, I don't know. It's there was some informaticians that programmed it that just took some different measures from the face to compare with each other. So to me, that's a black
I
box.
think one slide you skipped that slide, and I found that there was some neural network type of things were mentioned on that slide, but you skipped that slide. So
okay.
I just wanted to know what is the algorithm in that slide.
Okay, there's a publication on this where I took the slides from Gestaltmatcher. So I can give you the link to this publication if you would like to know more on this. Maybe that helps answering. I can't.
Hi, I have a question for Christopher regarding IND. What is the preferred way to go to the EMA or the FDA or both at the same time?
For which, sorry?
IND.
For IND is only for FDA, so that's an FDA specific term. Sorry to be specific. So CTA would be for Europe. So basically, but it is a good question because I'll tell you why. Because in the EU, if you want to do a clinical trial, you have to have clinical trial application. But that doesn't apply to the US because it's not the same legal structure. But you can do an EU clinical trial with a CTA and also inside an IND if you want to, even though the IND doesn't give you the right to do the study. But what it does is it means your clinical trial here has been approved, let's say by FDA. So the data you will generate will be sufficient for them to then do the next step, to do the marketing or to do whatever, if you know what I mean. So it's kind of like a double validation. But maybe if I just go the question a bit further. So there's a lot of procedures you can do with EMA and FDA, like an orphan drug designation, even the pediatric assessments you can do. So if you want to do them together or apart, is really a strategy for a company. Most companies don't do them together, which is something we've always asked why, but people get paranoid basically. And FDA and EMA, when they sit in the same room, it's a case of who's got the bigger one. Oh, I've got to say this because they said that. And suddenly you end up with more than you would if they were apart because they're like not competing with each other to be the most dominant regulatory agency, if you know what I mean. So yeah, it kind of works a bit both ways, yeah.
Well, I thought you were standing between us and going to the beer, but I think Ian wants to be the one. I would have expected him to be there. You have the last question, and after that we should wrap.
Yeah. Wow, there's pressure. It's actually quite a beer question, actually, as well. It was, I guess, mostly for Chris, also Hilary and Russell. Many of us are slightly nervous looking across the Atlantic of late. And you mentioned Mr. Kennedy a couple of times in your slides, and I just wondered, what does this potentially mean for rare disease research? What's going to happen? Because you can see maybe the NIH will be disbanded, or maybe it will suddenly become incredibly easy to get drugs approved because there might be some money in it. Can you kind of speculate one way or the other what might happen and how quickly?
I think that's for unconscious on the ground. So there's a lot to say there, maybe. If you want, I'll give you a slightly weird story just to go on. But I have a client who's a US client, right? And he's actually like you guys. He's got a son who's got a rare disease, but he also happens to be self-made millionaire, a rock star, and a writer. But he's created a biotech company. But he's also a friend of Robert Kennedy Jr. So he keeps telling us about his calls with him. And, you know, he was a bit unhappy when he went to Trump and this, but I think now he doesn't care because he lives in Florida. But he keeps telling us he's going to give Robert Kennedy a call and he can ring him up and now push through his gene therapy for his rare disease because he's friends with Robert Kennedy, who's going to run the FDA. So I'd like to see that happen because it would save me a lot of work. But I think the point of Robert Kennedy is ridiculous to the extreme. And so I'm not supposed to talk about politics and things, but on one side he's like anti-vax, but on the other side he's, you know, doing all this stuff and FDA is killing everybody and, you know, Fauci out and all that kind of stuff. But clearly he's missing quite a few marbles and doesn't know anything that he's talking about. And if he really gets in charge there, he's going to basically even further remove the confidence in these institutions that exist. And we have to remember, this is not financial institution. This is a scientific medical institution run by medical people, patient groups, lots of people who have extreme experience. And he's just going to come in with no experience and say, I know more than you because I read something on Q because that's what, oh, sorry, not Q, X, because that's where his friend Elon Musk also works. And, you know, so I suspect that if they do these things, it's what the right-wing guys have wanted all the time. They don't want regulation because it means more money for them. They can do whatever they want and they don't have to have responsibility, basically. So he'll probably find that his dream becomes a bit of a nightmare once he gets a dodgy stem cell treatment or this and that, which is exactly what they're going to ask for by doing that kind of thing. That's my personal opinion anyway. So.